Hey, good afternoon. Jose Almeida coming to you from Miami. And today I just wanted to share a pretty routine case just to let you guys know how we do things down here at Miami Vein. Young lady presents with bulging varicose veins and pain. And we found great saphenous vein incompetence, and the incompetence or the reflux was in continuity with the bulging veins that we see on the calf. And of course, there's many ways to do this. We like to do things at the same time, a combination of thermal ablation of the saphenous, ambulatory phlebectomy of the bulges, and then usually we'll go ahead and inject some foam sclerotherapy on things that we see underneath the skin. So let me show you, if I'll just share my screen here and just run through a few slides to show you what I did here. So obviously we're here in our office space lab, the left leg on the table there, our ultrasound, these are our devices back here. And let's just, let me get this out of the way, this bar, so I can show you here. So here we're scanning and the gray saphenous vein in the saphenous canal, which I'm sure most of you have seen. And what I want to show you is this perforator, the femoral veins down here, and this perforator, tortuous perforator coming through the adductor muscles and winding through to the distal thigh and causing some varicosities around the distal thigh and calf. But you can see that the perforator, I'm just showing here in the calf, some veins on the surface here. These are the two gastroc veins. Let me show you down here. These actually look like perineal artery and vein. Here's the tibia. Here, obviously, so we see a bunch of little branch veins underneath the skin that ambulatory phlebectomy will not reach. So these are the ones that we tend to foam. The ones that are marked are bulges that we feel, but I was trying to show you that underneath the skin here, there's a bunch of veins traveling, and we can't reach those with a hook. So we like to go ahead and foam those. So now we'll show you, I'm going to inject up here these varicosities that were in continuity with the perforator in the thigh. So here you should see a needle coming in, and obviously with ultrasound guidance, I like to use, this is physician compounded foam, 3cc syringe with a 25 gauge needle. Here you see in the vein lumen, and now as we inject foam, we're massaging it up the thigh with ultrasound. Here you see the foam casting the shadow. All right, so let's now keep going. We didn't inject this part of the perforating vein. You see the foam up here, but it didn't reach here. So we're going to go ahead and inject this now. We're going to go a little deeper. You should see a needle coming in here. There it is. It popped in the vein, and there's foam injection of the tortuous perforator that's coming off the femoral vein. Here it is, the foam as we massage it in. And then I want to show you that we're going to get some foam in the femoral vein. Here's femoral artery and vein. And you start seeing a little foam floating on top of the femoral vein here. So this is something that almost always happens when we inject foam. Some is going to go in the deep system. So we like to do some do some active dorsiflexion, plantar flexion to help move some of that foam along and get out of the vein. I promise you, it's not going to cause a DVT. We see this every day, foam in the deep system, and it'll just wash out. All right, so don't let that scare you. You can't control foam as well as one thinks we can. And here we see the deep veins. I'm going to show it to you again. Let's keep moving. All right, so now we're going to go ahead and place our tumescent anesthesia around in this case, we're going to use radio frequency, the closure fast device. Here's the device, and you're going to see some tumescent anesthesia. Here's the needle getting in the perivenous plane, and we're going to completely surround the vein with tumescent anesthesia. I'm sure that's something that you've all seen at this point, right? No, nothing exciting there. Now, here's the tributaries that I was telling you about underneath the skin. Some of them got foam already from our previous injections, but we're going to go ahead and get set up here to inject some more. Needle, injecting this one, and then as we send the ultrasound probe up, you see the rest of the tributaries filling as I'm injecting with foam, physician compounded foam, right? You can see the foam filling the branches. Sorry, I'm moving a little faster with ultrasound. All right, you see foam in the tributaries. So we'll remove the big ones, and the smaller ones got sclerosed. Here's some more tributaries on the anterior shin. Here's the tibia. We're going to inject this vein right here. And the reason we do this, some of it will remove a phlebectomy, but there's always fragments left behind. And if they've been foamed, there's a greater likelihood that they'll sclerose and not be a source of recurrence. Right there it is. As we go up, we injected that vein right there. And then I just want to show you this. I like to, so we're about to start our ablation. There's the catheter at the saphenofemoral junction, common femoral vein. And there's our catheter up here. And I like to, the radiofrequency heating element is 8 centimeters long. What happened there? So the ultrasound probe is 4 centimeters long. And because this device works by conduction, I like to use the handle of the RF device and help compress the vein while I'm doing the ablation. So let me show you that. Here's I am with the bringing the handle of the device up. And I'm going to use that longitudinally to compress. So I've got the ultrasound probe compressing and the handle compressing. And I like to visualize it as we activate. So there are typical 20-second cycles ticking down. And we're going to give 2 cycles at the saphenofemoral junction, which I'm sure you've all seen. It probably used this device by now. All right, we're going on our 2nd cycle. And we'll let that clock tick down. And then we're going to pull the catheter back as we get ready for our next cycle, just pulling it back. And I'm sure you've all seen that. Then we get ready to go again. And then finally, we're going to put our tumescent anesthesia for the phlebectomy. Remember, we get this peau d'orange effect, subcutaneous tumescent, and this stuff works like magic, makes it hemostatic, has bactericidal properties, and that allows us to do this in the office. And here's a phlebectomy, which I'm sure you've all seen. Just make a little incision, bring it up with a phlebectomy hook. So the veins around the knee, give it a little tug there. I always use an assistant, other people don't. In this case, we're going to bring up a loop of vein and bring up a loop, and then we'll clamp and divide it. And this way you can get a good segment of vein from the bottom and the top. So we're going to do the bottom first. See the skin tenting down here. We're moving all this vein here to that little incision and do the same at the top. Right, little segment of vein. So you can see we pull it out in fragments. So the stuff that we can't get out has been foamed and that'll sclerose. And that's it. So I'm sure most of you have just unshare this. So I'm sure most of you all done saphenous ablation, phlebectomy, and foam sclerotherapy by this point. Why do I do it all together concomitantly? This is a way I'm in my 27th year of private practice. This seems to be what the patients like. Patient satisfaction is high. Does it make sense from a reimbursement purpose? Way of thinking? Probably not anymore. I think that's why a lot of people are staging things because of the reimbursement. But I've just an old dog trying to teach me a new trick type of thing. This has always worked for me, but we're getting hit with reimbursement. But we like to do everything together, the ablation, the phlebectomy, and the sclerotherapy. We will see more little tibial vein thrombi than if you do a staged. We think this is mostly sclerosis, not thrombosis. So we'll see these little calf vein areas of sclerosis with ultrasound. And if we're worried about them, we'll just follow them the following week. Rarely do we have to anticoagulate them, but sometimes we will for a week until it retracts. But that's really the main side effect of doing everything together. Patient satisfaction is higher, but you'll get a little bit more thrombosis of the calf veins, which usually are innocent. So that's it. Signing off, Jose Almeida for IBC Community. Thanks. Hope you enjoyed.